Dr. Hirlock, and good evening, everybody, and thank you for your opening statements. If we can go to HICWA first, Carl or Finbar. You're saying that you have the right, obviously, and we know that, to inspect centres. Centres have to be registered, I believe. And how do you ensure that all centres are registered, that should be registered? Because I would be aware of some organisations that might not register services because of fear of HICWA going in, but it should in fact have their services registered. And I suppose, are your visits announced or unannounced, or kind of a mixture of both, or what kind of breakdown is it? And I know you talk about you engage with the residents there. Can you speak to children without an adult present? And then also, how do you, I suppose, communicate with someone who has communication difficulties? I mean, some people may be non-verbal. And also, that some could be fearful of telling the truth if they're afraid of a staff member. So it's just, you know, and I'm talking, most centres are very good and the staff are very supportive, but there are instances where they're not, and it's just to ensure that people are able to tell the truth. And I suppose, do you provide any support for people who are whistleblowers or who make protected disclosures as well? Just on the Ombudsman for Children's Office, just to commend your report, Nowhere to Turn, and you know, I think it's very important in highlighting what was happening with families feeling they're forced because of the lack of supports to leave their children in hospitals or respite centres or schools. And I mean, I've met many parents who maybe have a teenager, or maybe someone who's just turned 18 or 19, and who have felt they had to contact the guards because of behavioural issues, and ended up then the young person being removed from the home, which is not what they wanted. What they were looking for was support, and they didn't get the support. And I know of a number of cases where the person has been referred to a mental health institution or a mental health unit of the local hospital and detained there on the Mental Health Act. And this person doesn't necessarily have mental health issues. They may be autistic, they may be combined with other issues, and it's because of the lack of support they received in the community from the CDNTs. They may have developed behavioural issues, but it's not a mental health issue, and it's not the right place, it's not the appropriate place. And the hospital may actually recognise it's not the appropriate place, but they will say there's nowhere for them to go, and all the family want is that person home with the appropriate supports. So I suppose, and then many families as well refer or have their children referred to CAMHS, and they're put on a waiting list. And this can go on. If the child's assessed, sometimes they're told, no, you're not appropriate for our services, and they're left in limbo. There's nobody to support them. Or you're told, yeah, we will accept you, we'll give you an appointment in 6 months. 6 months is no good to a young person who is threatening suicide or is self-harming. So there are huge, and I know both Mental Health Commission and the Ombudsman, you've talked about more joined up thinking that our services are siloed and we need one point of contact. And you know, that's been talked about here in this committee several times. It's been brought up with different ministers. There isn't cooperation, and there needs to be. But our biggest problem is that none of the services are properly staffed. The CDNTs are understaffed, CAMHS are understaffed, and some of the CAMHS teams are excellent, but some of them are not providing the support. There seems to be an over-reliance on medication that is not monitored, and a lack of other interventions as well. And I suppose the Mental Health Commission, you have no remit over CAMHS standards and rules, but you say that the powers to do this can be granted under current legislation, so why haven't they been? Because we know there's huge issues with CAMHS. And that, and just when you say you have the power to inspect inpatient services, does that extend to the psychiatric wards in hospitals as well? You know, I suppose, yeah, that's just to kind of, just to expand maybe on those as to why, or what's like the roadmap for disability that's recently been launched has indicated that they're going to have an overall or working better together, you know, but it's just to see how could that happen in the shortest possible time. And I know you talk about HSE and TUSLA working together. I've heard stories of HSE using TUSLA as a threat to parents who are maybe just expressing exasperation with trying to support the family, and the HSE, well, no, maybe we will report you to TUSLA. Whereas I know TUSLA is there to support a family as much as it's not there to take away the children, you know. So, but that seems to be the threat. But anyway, thank you.
In relation to registered designated centres, not all residential centres would meet the definition of a designated centre, so it depends on the level of care and support that is required, the type of service, how much control the person has over their own living environment, whether they have their own lease. So we updated our guidance on the definition of a designated centre, and we included scenarios to help providers to ensure that when they are looking at either setting up a service or where circumstances change, that somebody may have been independently living with support and the circumstances may change, that now level of support is so great that it becomes a designated centre. So we updated that and we issued it out to all providers, and it's also up on our website. If in order, I suppose, we sometimes hear from word of mouth, we sometimes get concerns sent in to us. People may be ringing us saying, are you aware that a service is in existence? And we would take that, we would risk assess it, and then we would do, we have to be invited into the service because the Act doesn't allow us to go into an unregistered designated centre. We only have rights to enter into a designated centre. So we would contact the provider, we would request for them to invite us in so that we could do an assessment, and we have a criteria by which we would assess that service. It is the provider's responsibility to ensure that they adhere to the Act and the guidance that we have issued, and assess their services to make sure that if circumstances change, they make an application to us. One of the areas that is of concern to us is that we don't have any legislation for emergency provision. So similar to what our colleagues were talking about when somebody is in crisis, the capacity within the designated centres is very limited. So if a person, a child or an adult, family breaks down or they need placement and care and support, sometimes that requires the provider to contact us and say, can they open up a centre and submit into us an application? And that person is in genuine crisis, we'll assess that and we'll discuss it with the provider. But we don't have emergency registration, and we're working with the department to progress that because it is definitely a gap within the legislation. In relation to announced and unannounced inspections, about 70% are unannounced last year. We try to announce one in a 3-year cycle, and the reason we announce this is to give families advance notice of when we're going to go if they wish to make arrangements to come and meet with us. And that's the sole purpose of an announced inspection, is to give residents and their families an opportunity to meet with us. During COVID, we didn't do those announced because of visiting restrictions, and we're looking at how we can re-establish that practice to give people notice that we're coming. As we said in the opening and in our overview report, meeting with people and getting their lived experience is hugely important to our methodology of how we inspect. Some people have communication difficulties, so we will observe practices, we'll observe how they live their life in that centre. We'll only talk to children that want to speak with us, because we're very aware that we don't want to put children at risk. So we will talk to them. We will tell them how they can get in contact with us or their families after the inspection, and sometimes people do. And then if people can't talk to us, we observe. And we, over the last year, have put a greater emphasis on that section of the report in what residents told us and what we observed on the day of the inspection, to really describe what it's like to live in a centre from the experiences of people living in that service, and how they're integrated into the community, how they are supported to do what they want to do, to play, to access education, as they're transitioning into adulthood, how that is supported by the provider. We have two roles in HICWA in terms of protected disclosures. We have the internal role in terms of our own staff, but then we also are authorised in terms of receiving protected disclosures under the amended 2014 Act. And that puts quite a lot of emphasis on taking that protected disclosure, the confidentiality around that, the protection for the person, the opportunity for them to meet with us. And we have people authorised to meet with people who wish to make a protected disclosure in person. And then also that the amendments to the Act require that we would either give that person back notes of that meeting, or if we recorded the recording of that meeting. So we have that is set up, and we are in receipt of protected disclosures. We then take that information to inform our inspections. So the content of the concern that they're bringing would be passed to our inspectors, and they would assess, risk rate that, assess it, and determine the best course of action in relation to it.
Thank you very much for sharing those stories of parents that have come to you. And I think when we published this report, there was a sense of disbelief that this was happening in Ireland, that parents were being left in this situation, that they had to leave their children behind simply because there wasn't enough supports, even though they were loving, caring parents. So I think the more we can share those experiences is just really important in order to try and affect change. I think the example that you gave in relation to the young adult that was in a mental health facility, I think that's what's really important. This is the profound adverse effect that happens to children when they don't get the services that they need at an early stage. As this committee has a specific role in relation to the UNC PD, I just want, if you'd indulge me, to read out Article 23, because this is a critical one. The state party shall ensure that children with disabilities have equal rights with respect to family life, with a view to realising these rights and to prevent concealment, abandonment, neglect and segregation of children with disabilities. State parties shall undertake to provide early and comprehensive information, services and support to children with disabilities and their families. So you can't help but wonder what would have the life of that young person have been if he had gotten and his family got what they have a right to. Yeah. So that's just a really important right to focus on with respect to this committee. So thank you.
The main issue here is that our remit is just to do with inpatient units, mostly adult, and then there are 1 or 2 children and adolescent inpatient units. But as regards community services, we have no remit, especially for children, and we can't set standards. And if you want to run anything, any type of service, the Oireachtas, anything, you need to have standards which people can be called to account for. And that's what the Mental Health Commission has been doing for many years. HICWA have been doing it also. But we cannot do that at the moment. And the inspector has, the previous inspector has indicated, and the Commission is fully behind that request, and we've made it to the Minister of Health and the Minister of State that we be given the powers now to set the standards, and from setting standards then we can follow on and inspect to make sure the standards have been adhered to, but they're not there at the moment. We've no remit over places where a lot of children end up, which is A&Es in general hospitals, paediatric wards in general hospitals, and I'm sure you know from experience, we know that children are ending up in those settings because their parents are afraid that they're going to harm themselves or afraid they're going to harm a member of the family. And there are then the 2 groups of children who might need admission to somewhere. One are the people who have definite mental health problems that cannot be treated as outpatients, but the other are people you've referred to who are inappropriately placed, don't have the right supports and are acting out, but they don't have a mental illness. So I've worked for 20 years with people with autism, with and without intellectual disability, and as late as last week I was dealing with a young man who didn't have a mental health problem but was causing amazing distress to everyone around him. So it's not a new problem, but we still don't have resources for it. We've long held that children should not be admitted to adult psychiatric units, but it's still happening. But it's something that we report on and that we're not in favour of it. And Professor Lucy might like to comment on that.
Charlie, you mentioned general hospitals, which has sparked the particular line of comment that our chair is making, and it is important to understand that we don't have access to standard setting or regulation of those. We can inspect, the inspector can inspect anywhere where mental health services are provided, or mental health activity in sense of needs is being addressed, but we can't set standards for those locations. The situation arising where a child is admitted to an adult unit is one that is a breach of our standards, and we find centres, approved centres, who often through no better alternative are forced to do that. We find them in breach of that standard. But on inspection and in dialogue with them, we work to encouraging the either the proper discharge of that person to a community service, or the transfer to one of the 6 approved centres who, which are designated for the care of young people in the country. Those centres we do inspect. Now this becomes very, very problematic for many centres. In my 4 months in this post, I've already come across this, and Dr. Finnerty does mention the inequity and the divergence of access that is really problematic. So that there are several CHOs that have an approved centre for young people that would be regulated and would provide inpatient mental health services of a standard, but there are others that do not, and they have an arrangement. I shudder to call it a grace and favour arrangement, but an arrangement within the service that they can have access to the other unit outside of their county, within a CHO, for example. But these arrangements are often very strained and tenuous, and certainly delays occur then where an individual, a young person, is inappropriately placed within an adult unit. No one wants this to happen. It has fallen in instance. The number of instances are falling. I think the awareness of that is something that is a good thing, and has resulted from the work of the Commission and of my predecessor. But it's an unacceptable experience. There is a nuanced part, I won't go on too long, where young people who are on the cusp of adulthood, as we might say, so in your 17th year, often physically, apparently, with the strength and the vigour of a young adult, are nonetheless children. And that can be a real problem for services, because they simply don't have the appropriate place to care for those people, and they often have mixed mental health and personal, social, and sometimes intellectual difficulties, with or without the mixture of issues such as ADHD or consequences of drug abuse. Very complex, challenging issues, and unfortunately their experience of mental health intervention in an adult setting may be their very first inpatient exposure to mental health care. And experience from research and from other jurisdictions tells us that the first exposure to mental health care is often the determining one for a future outcome. If it's a bad experience, that's a very unfortunate indicator for the likelihood of a successful intervention over time. And so we really do have concerns about young people being admitted. I'm sure there are centres that do their best and try and accommodate within an adult setting, but nonetheless it's inappropriate.
Clarify that when I said dealing with the young person last week, it wasn't as chairperson of the Mental Health Commission, it was as a clinician. So it's an ongoing problem, and obviously someone with autism shouldn't be in an adult psychiatric unit, whether they're children, adolescents or adults, because it's not the proper environment for someone with autism, and yet we lack facilities to support people who have ASD and have behavioural issues associated with it. One other thing you asked about was the staffing, and it's an interesting issue from from Dr. Finnerty's report, that there were units that weren't there were teams that had problems with staffing, but they were still providing a reasonable service. So even though staffing is really important, there is an ability for some teams to work in a different way that allows them to maximise the staffing they have. And we also know from Dr. Finnerty's report that the teams that were very well governed, using the term as an administrative and a clinical fact, were the ones that were attracting staff and had less problems getting staff. So going back to what I said at the start, the issue is governance.
Agree with you.